Hello and good evening. It is my great pleasure to welcome you tonight to our CVI webinar on hemodynamic support for PCI, when and how. This is actually a CME event, so you can get CME from this. To get the CME, you go to the website, CV Innovations, Cardiovascular Innovations. And it is my great pleasure to welcome you, an amazing faculty from different parts of the US. We have Dr. Khaldun Alasvad from Henry Ford in Detroit, who has tremendous experience in all sorts of hemodynamic support devices. Then also Dr. Arasim Maran from the Medical University of South Carolina, also tremendous experience in complex PCI and hemodynamic support. And then Dr. Jader Sandoval from the Mayo Clinic, who will actually be the one closing the session and also has a lot of expertise in managing of these devices. I would like to thank Abbott, Boston Scientific, and Medtronic for supporting this webinar. And this is the address if you would like to get some CVI CME for this participation. Also, just to remind you that next week there is a unique new webinar in which actually Dr. Shoraja will talk with several imagers to highlight the interaction between the interventionalist and the imager when doing structural case interventions. So I'm going to stop here. Again, welcome everyone. And we're going to start with Dr. Alasvad, who's actually may have to go for a STEMI tonight, so we'll have him kick it off. So again, Carl, thanks again for coming today and looking forward to seeing your cases.
Good evening, everybody. And this is Khaldun Alasvad from Henry Ford Hospital in Detroit. And we can unfortunately and unfortunately developed a tremendous experience in mechanical circuitry support devices. And I'd like to highlight some of the lessons we learned through these years by kind of presenting two cases. And I'm going to try to present them really fast, and you guys can stop me and ask questions. These are my disclosures. So when you trying to do a complex PCI, so when you're trying to consider doing a complex PCI, you're always faced with a question: should you use mechanical circuitry support? Which mechanical circuitry support, if yes, and when to wean the mechanical circuitry support? And more importantly, with something always kind of comes as afterthought is the complications. And honestly, the complications of mechanical circuitry support devices are huge and tremendous, and they could be detrimental. So we and others developed this kind of scheme, this Venn diagram. We consider hemodynamics, patient, and procedure, and probably the next speaker is going to highlight that more than I'm going to do. So I'm going to start with, I kind of prepared two cases, and they are kind of both highlight different themes. So 58 years old patient who presented with non-STEMI pulmonary edema, lactic acidosis, and requiring intubation, severe heart failure. She spent several days in the hospital. They do a cath for her, and these are angiogram. She has a very poor target and diffuse disease in the LAD, occluded posterolateral branch. And basically, she has all the findings of needing a bypass surgery. However, in this day and age, the surgeon said, well, these targets are really poor and we're not going to do that. So and she showed up in a different hospital. So basically, rightly so, they thought medical therapy, because really they did not have the expertise or the wherewithal to kind of perform these procedures. She really did not have much mitral valvular regurgitation and poor target. She has carotid and vertebral artery disease and diabetes. And despite that, she was not a deemed candidate for bypass surgery. Now, 3 months later, she get admitted with this chest X-ray, EF 35%, acute respiratory failure, and the same thing all over again. She spent 5 days in the cath lab, and she was discharged. On the same day of discharge, she comes back in the evening with even worse pulmonary edema, right? So this lady, every time she gets up with these coronary artery disease, she gets flash pulmonary edema. She transferred to our hospital after the third or fourth admission. We basically decided to take her to the cath lab, and she was optimized. Her volume are really optimized. Everything is good. She was talking. She was laying flat, edema is gone. We said, okay, we're going to do that with no basically.
Quick question for you, because that comes up quite often. How much and how long do you wait to optimize patients like this? So I know that, I personally have been burned sometimes. You try to go a little too early. The patient is not fully optimized and the wedge is high and then they don't do as well. So do you have a specific time frame or just wait to see how the pressures are? How do you optimize? And is it you or is it the heart failure team that usually manages these patients on the floor?
It's both, but like the management. So the optimization, and honestly, it's controversial. And I don't know how, sometimes you cannot optimize those people. And that's where the role of mechanical circulatory support devices. And in this case, actually answers exactly your question. She was optimized. So normally we would like to have her be able, the patient laying flat, because this is basically the thing. We want the patient to lay flat on the table and have a good oxygenation. And by physical examination, but it's better to be guided by right heart catheterization, honestly. But that require ICU admission, and it logistically sometimes is not feasible. So this patient, we crossed the left circumflex, and my partner basically dilated it with the balloon. It was very hard to dilate, and after the first balloon dilatation, she goes basically crashing. We had to do right heart cath and we put a balloon pump. This was her chest X-ray, and this is her numbers. PA pressure 86/36, the mean of 60, her pulmonary capillary wedge pressure 42. So that actually goes to your question. She was really optimized, and I made sure myself she's optimized. I was kind of rounding, and we said, okay, this is the day to strike. So we struck. If you notice, we did not start with right heart catheterization, but the minute she crashed, we put right heart catheterization. So the optimization is, first of all, sometimes it's difficult. You can't do it, and sometimes require mechanical circulatory support. You put them in the ICU, you diurese them, and you get them optimized, and you bring them. You cannot use inotropes because the patient actually is ischemic by definition, so you shouldn't use dobutamine, but sometimes you could use it, and milrinone. So the optimization is really, that question is not answered yet. And if you look here, when we aborted the procedure, we sent her to ICU, we did a TEE, and this is a classical mitral valvular ischemic regurgitation. We could not actually, once she's intubated and relaxed, we didn't demonstrate much MR, but there is like the posterolateral wall and the leaflet is tethered. So how would you treat this patient now? So we took her back. Actually, we extubated her again, and she came back to the cath lab. So what would you do, right? So for sure, everybody gonna answer, we're gonna put a mechanical circulatory support devices, and her main etiology is severe MR when you basically cross that left circumflex. Now you have to remember her vessels were really calcified and we couldn't dilate them with the balloon. So we're gonna have, procedure-wise, we're gonna have to use atherectomy. So which device would you use? And honestly, the choices of these devices are really kind of tremendous. You can do a balloon pump, which is, it's a thought. You can do Impella 3CP or 5.0, and the 5.0 will require basically sometimes transcaval access, which we do routinely here. And I like this device, which is a tandem heart, which is actually goes from the left atria and takes the blood out and pumped it in the aorta through a 15 or 17 French cannula, and I used it on her. So I actually decided to do this because from a previous experience, and this is all anecdotal experience, when you have a mitral valve etiology, the best thing is to, especially if you have mitral valvular stenosis, but also if you have mitral valvular etiology, I think the Impella might be good, but the Impella does not provide enough support if you're really, really sick, and you have to use the 5.0. The 5.0, 21 French, or 22 French, sorry, and it's bigger and it's doing transcaval. So I actually prefer the tandem heart. So in the day of must examine, if you do mechanical circulatory support, you really have to be good in access. You really have to be, you cannot really be kind of mediocre in access and managing large bore access and managing the complication. And if you notice, this is basically her right heart catheterization. She improved the pulmonary capillary wedge pressure still 20. Her cardiac output, cardiac index are good, and her CVP is a 12.
What would you do in this case? What support device would you use?
Honestly, I know Calvin is a big fan of the tandem heart, but there's a little bit of a difference of opinion. I would not, in someone who's crashed and burned, I would have preferred to continue with the intubation, and I would have continued with the right heart cath all through the procedure and used the right heart cath continuously. So I would have just gone, I would have tried to, medically optimize as long as I can and then go with an Impella, only because I don't do a whole lot of tandem heart. So Impella and VA ECMO would have been my choices.
Yeah, I agree, and I think the discussion of the medical optimization is interesting to me. It's of the clinical context probably will dictate what happens. If the patient has ongoing active angina, you probably have to bite the bullet and act right away. But if there are opportunities for maximal medical optimization, I think that's nice. And of course, there's different lab setups. There are labs that have anesthesia in the same cath lab and a lot of support to deal with patients that have tenuous respiratory condition and so on, and others that don't. And I think those things sometimes need to be taken into consideration. But I would do probably the same thing: medical optimization and Impella.
Yeah, absolutely. And the Impella is actually it's a very good device. From my experience, it's really good when you have moderate, like a kind of reserved dysfunction, like the reserve is reduced. But when you're really, 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 really sick, you need to go to bigger devices, either Impella 5.0 or ECMO or a tandem heart. And I like the tandem heart because we've shown a lot of kind of when the patient have to leave the patient on it, it's actually the patient do really, really good. And most of them win really good. And there are some data which shows that actually the ventricular unloading is better with the diastolic ventricular unloading is better with a tandem heart than the CP or the 2.5. Anyways, so basically, if you notice here, this is for those who want to learn tandem heart. You basically, and the tandem heart is very important when you have mechanical aortic support, and if you have an LV thrombus, the only choice is the tandem heart becomes, or ECMO. So basically, a transseptal puncture, believe me, it's really easy. It's not that difficult. And we don't see much complication. And our EP guys and our structure guys do that routinely. I use that under ice. And this is the cannula here, 21 fringe. Of course, this is left circumflex ramus are the culprit in each presentation. Diffuse disease, LAD, not good target for stent or lima. And PLB is a CTO. So if you notice here, I'm using road ablation, and the patient really stable throughout the road ablation. And we stented it, and we directed into ramus and treated it. And this is and finally, I actually used 2.0 by 40 millimeter balloon in the LAD. And the patient actually went home in 2 days after that. Weaned the tandem heart cardiac output, cardiac index through the right mechanical. The right mechanical allowed us to achieve functionally complete revascularization. We still have the posterolateral branch, enough time to optimize the PCI. So one of the things when you can sometimes get away without mechanical circulatory support, but you have to remember you're going to be under stress, you're going to be stressed out, and you're going to really be doing a shitty job trying to optimize these vessels, and you will avoid like kind of balloon inflation, enough balloon inflation. So once you have a mechanical circulatory support devices, as if you gave yourself enough time to basically perform optimal PCI. And you can prevent basically the spiraling and cardiogenic shock that happens with it. And basically, since the MANTA came available, we used to pre-close. We weaned their right heart catheterization. It's very important to determine the wean, better to choose the right mechanical circulatory support at the start. So what we do, it's the worst thing to do is to choose a device that's not enough, and you have to escalate either in the middle of the procedure or after the procedure. So you always have to factor in the access. Like let's say you're treating a patient who does not have access. So sometimes you need to put a mechanical circulatory support because it really takes a lot of time to put an axillary access. that as opposed to common femoral artery access, just because you know that your procedure, you might need it later. And you have to think about, if you're leaving the mechanical circulatory support device, how are you gonna ensure that leg perfusion throughout the days after it? And you have to think about, when you close the mechanical, you need to have a really good access technique, and then you have to have a bailout strategy. So you really, when you do mechanical circulatory support devices supported PCI, you are dealing with two procedures. Each one of them has significant complications and they affect each other. So if you end up with a perf in the PCI and you have the mechanical circulatory support device in, and the patient, you have to leave it in, you have to remember, you cannot stop the heparin. So all these things have to go. So when you do the PCI, you really need to be 100% sure not to have a perf or a rupture vessel, and you need to optimize your procedure by using IVUS for sizing and making sure your wire doesn't perf. So basically, this is just an example of a patient. This is going to be a fast example. This is 62 years old patient, diabetes, history of alcoholism and cirrhosis, and HFrEF EFS 15%. This is his RCA, non-dominant. But if you notice, there are some kind of collaterals trying to go to the left and wait for it. This is his left main. So this guy has significantly calcified left main with basically a very small channel. And if you look, the circ also has a small channel. So when you do when you have doing high risk PCI, you really have to have all the toolbox in your armamentarium, including the mechanical circulatory support devices. And I will argue, in this patient, you really have to have a very big support, because he has non-dominant RCA, and if this left main closes, that Impala is not going to save his life. So video visit, believe it or not, he was at home with these caths, felt dominant left circumflex subtotally, and how do you approach this, right? And I'm just going to go cut to the chase. The consideration here, PCI has to be optimized, skill set, full toolbox, no PCI complication, bleeding, perf, thrombosis, no mechanical circulatory support device complication. You have to factor in the limb, it causes more strokes. Bailout strategy, you have to have bailout strategy for everything you have, like the PCI. This doesn't work, you need to move to the next. And I'm going to show you what happened with this patient. It's really kind of strange what happened with him. Mechanical circulatory support escalation. I would like to avoid escalation by putting the largest device I can put from the beginning. You are it. Most patients have no surgical options. Those patients, he's turned down by surgery. So if something happened on the table, you're at. The surgeon is not going to bail you. ICU, your ICU have to know how to manage those patients. So again, we got access, and basically this patient either going to be a tandem heart or a LAVA ECMO or an ECMO or a 5.0 Impala, transcaval, or even trans arterial. So basically the valve, the guide catheter is just sitting there. It doesn't really engage because there's no left main. We crossed Viperflex tip, then it didn't go. Then I switched it with a microcatheter, and I was able to kind of wire it down. And if you notice difficulty crossing proximal LAD lesion, there was another lesion in the proximal LAD. CSI at low, then high speed in the proximal LAD, hemodynamically unchanged, stable through the CSI. Despite all this, like the patient was stable. The LAD basically almost shut down. There's not much flow in it. Despite that, the patient is stable. So what we did, because we still have to fix the left main, so I did IVUS guided PCI of the LAD all the way to the ostium LAD. And then if you notice, the circ here is struggling, but basically we were able to cross it primarily with the wire. And same thing, we switched the microcatheter. And so if you see here, it wouldn't go. And I actually had to primarily cross, like advance the microcatheter, and then primarily cross the second lesion with the Viperflex wire. And guess what? The CSI here, when you have to make decisions really fast and move fast, the CSI crossed the left main, but would not cross the second lesion. We treated the ostium left circumflex. We couldn't cross it. So immediately we switched to RhodaWire and we performed rhoda ablation. And we proceeded after that with basically DK culotte technique. In those hemodynamically patients who are tenuous, DK crush might be actually too much for them. Stenting in the left, and we did a pot, and we basically recrossed and restented. IVUS allowed us direct stenting in the OM, and this is the final results of this patient. He actually went home. I'd like to emphasize to anybody who's trying to do complex PCI, you really, in this day and age, you cannot do it without an IVUS. You have to have an intravascular imaging or OCT. IVUS, because most of those patients have renal failure too, so you have to have an IVUS, an OCT for those who have normal, and you have to optimize them long-term. Manta closure device, figure 8 for the vein, went home the next day. Mechanical circulatory support are very, very important of any PCI, complex PCI program. You have to have knowledge based and a skill set. PCI has to be perfect. You have to be really, really perfect and meticulous in these things. And you always have to be ready to manage two sets of complications, the PCI complication and the mechanical circulatory support complication. Must be comfortable with large bore access, and mechanical circulatory support is a team sport. You have to have a cath lab, CICU, CT, everybody has to be around you, and learn mechanical circulatory support your patient lives depends on. Basically, if you have any questions, you can call me, email me, or do anything you want. Thank you so much.
Awesome, Carl. Thank you. These are phenomenal cases, and obviously, for people watching, these are not your average cases, and to use them, you really want to be very experienced in using these devices. So, Carl, in the second case, you also used tandem heart. There was a question coming from the audience. Is that right? You used tandem heart on the second case as well?
Yes, yes. So
okay, perfect.
The second case, I would not use anything but either a tandem, an ECMO, or a 5.0 Impella. I think the CP Impella is really good, but in this situation, you have to think about what could happen if I do CSI or rotablation and the left main shuts down. So it's gonna shut down until you pull your balloon and everything. The CP requires internal. Like it doesn't require it really, but if the RV doesn't move, the CP doesn't move, right? And it does not pump. So if something happened, the RV get affected because the septal gets shut down. So the RV is not going to really be that effective when you have a dominant circ and all the septals coming from the circ and the LAD. So even you have an RV branch or RCA open, but you have to think the RV is not going to be lasting long. So you have to have a support device that can give you enough time in case of complications. So sometimes you put the support device, not because the patient in failure, just because you're doing a procedure, you're thinking, what could happen if I close that left main or the last available conduit? The patient could be 100% stable. So these are the studies that we haven't done, and these are the techniques. It's difficult to do, honestly. How are we going to perform these studies? We did show from the CVAD database that basically prophylactic mechanical circulatory support with Impella in patient with normal EF is practiced frequently, and it's actually showed good benefit. It's a registry data, so I'm not sure if we can really argue a lot with it, but like you have to remember that there's an art and science to medicine.
Perfect. Yeah, thank you so much. Any thoughts, Arasi and Yader, regarding Carl's presentations?
Cal, as usual, fantastic cases, and it also tells you your comfort level handling all these devices. And I think your point is absolutely right. You have to hope is not the best strategy, and you kind of prepare for the worst and hope for the best kind of a thing. the thing is, I can see that you are so comfortable with Tandem, and that is truly your first choice. How would you decide Tandem versus ECMO? I mean, I would think VA ECMO is easier because it's just large bore access. There's no septal crossing, whereas Tandem, there is a septal crossing, which is again an additional step. So why this versus that?
So if I have the choice, I prefer Tandem because they are unloading, right? So what happened with ECMO, you're actually loading the LV function. And the last thing you want to do in patients who have severe three vessel disease or severe left main is to increase the afterload, right? So the Tandem is unload the ventricle by basically taking the blood out of the left atria. So you still have a little bit stroke volume, but it's really, really minimal. So honestly, I think the ECMO will be preserved when you have a biventricular failure. And even that, to prevent that unloading, I still do LAVA, left atria venous ECMO. So what we do, we put one cannula with multiple holes all the way through the septal in the left atria and the right atria all the way down to the IVC. And we basically unload both ventricles, and the ECMO provide an oxygenation. So a patient who have a trouble oxygenating, you need to use an ECMO. The patient who can oxygenate, I think the Tandem heart is my choice. Now the transeptal is an added procedure, but honestly, there is a lot of the procedure is not that difficult. It's really the learning curve is really easy, especially if you know how to use ICE or if you have a TEE. And now most labs should have people who do transeptal frequently with all these structural heart cases. And you have to learn to do the Watchman devices. You have to do a transeptal very frequently. So I think you're right. It's an added procedure. I use the ECMO when it's emergency and I don't have time to do the transeptal and set up for it. So I just gonna throw an ECMO in there. And then you have to think, I'm gonna put an ECMO and then I need to unload the ventricle. You put an ECMO and you add an impella. And now you have two large bore axes as opposed to one large bore axis. So it is a really complex, and my preference is not to use ECMO unless there is an oxygenation issue or emergency.
Perfect. Well, in the interest of time, maybe we should go on to your cases, I think, because we can have time for everything. So again, thanks again, Carl, a phenomenal case, and Arash, looking forward to your presentation as well.
Thank you, Manos. Thank you so much. It's a tough act to follow, but I'll do my best. So we will start. There are a few things which are going to be redundant, but I'll go through them fast. So when do we use mechanical support for high-risk PCI, cardiogenic shock, cardiac arrest situations? So what is the purpose of it? As Cal said, reduce the left ventricular stroke work, reduce the myocardial oxygen demand, while maintaining systemic and coronary perfusion in the setting of cardiogenic shock, or to provide hemodynamic support during complex cardiac procedures. These are the series of devices available to us, and the support increases from balloon pump all the way to ECMO, and we've talked in detail about this. And this is the amount of support: balloon pump giving you up to 1 liter, Impella 2.5, 2 liters, CP 2.3, Tandem 3 to 4 to 4.5, and Impella 5 all the way to 5 liters, and VA ECMO more than that. So it's a balancing act. You might think you're jumping off a beautiful cliff into a great, beautiful lake, and there could be a snake waiting at the end of you. So you have to think about the pros and the cons, and that's where as Cal said, the art versus science of medicine comes in. And there is also a big difference between a high-risk patient versus a complex case. A high-risk patient is one at which the risk that there's a large area of at-risk territories, significant comorbidities, very little hemodynamic reserve, and ischemic preconditioning. The case is complex when you could have uncertain procedural outcomes, you have contrast limitations, and anatomical ambiguity. So the high risk other clinically can be decreased EF, electrical instability, decompensated heart failure, Comorbidities could be valvular dysfunction, severe lung dysfunction, end-stage renal, age greater than 75, cerebrovascular peripheral disease, or acute coronary syndrome. And high-risk coronary anatomy could be the last patent vessel or an unprotected left main. So from when you're thinking about the procedure, you have to think about the hemodynamics of the patient. What is the case itself? What all do you need? And the axis on the patient. Filling pressures, cardiac index, systolic blood pressure are all tools for you to figure out, help you evaluate. What is the ischemic burden? Are you going to use atherectomy? What all can you anticipate, like vessel shutting down, perforation? And what is your vascular access, and what is the bleeding risk of the patient? And based on this is the proposed algorithm for mechanical circulatory support. And based on this, whether you have 0 to 2 or 3, where you definitely consider support, and if it is greater than 4, you would strongly consider support. Now, this is a 65-year-old male with a non-ischemic cardiomyopathy, EF of 32%, admitted with heart failure, routine angiogram, and LV-EDP is 32. And you see this osteal lesion, and you're like, oh, this is a simple osteal lesion. I can quickly stent it and get out. And of course, we put a stent in, patient crashes, there's PA arrest after the stent deployment, and then you have an impella in place. So the goals of your mechanical support, circulatory support during high-risk PCI is to avoid crashing on support. So therefore, you want to optimize heart failure in case of a decompensated patient. You want to choose the right hemodynamics to prevent the decompensation because of ischemia during intervention. And you do not want to rely on inotropes or vasopressors so that you can avoid crashing onto the support. So based on that, reduced EF or normal, mildly reduced or normal EF, you can think of a balloon pump or impella. Rarely, very rarely is balloon pump used these days. But when you have severe systolic dysfunction, think of impella, and then other choices based on vascular access, and ECMO for concomitant hypoxemia or RV failure. So this is again a proposed algorithm by Atkinson et al. For mechanical circulatory support for shock, arrest, or high-risk PCI. The bottom line is this is not a one-person show. You need a heart team. The interventional cardiologist, cardiothoracic surgeon, cardiac anesthetist, CV-ICU nursing staff, and an echocardiographer are all in together to figure out which is the right device for the right patient. So while you're thinking of all this, PA catheter is your guide. It's the canary in the coal mine. It orients your trajectory. It sticks the landing for you. So PA catheter is pretty much essential for all these cases. So here is another patient with a 68-year-old with COPD with EF of 30% and troponin of 0.8. And you can see this terrible looking, pretty unstable left main lesion, hard to miss. But when, do you want to discharge this patient on hospice? What are your mechanical circulatory options? The left leg has very poor pulses. You can see a right iliac stent on fluoro. Axillary arteries are pretty small, 5 millimeters. When we did the right heart cath, RA was 5, the wedge was 10, cardiac index was 2.7. Therefore, we went ahead and proceeded with the left main circumflex with OCT guidance without any circulatory support. So this is what the PA catheter measurements helped us to do it. And then moving on to another patient, again, new onset heart failure with a EF of 22%, RCA-CTO, diffusely diseased tortuous LAD disease, and kind of looks like a severe-ish lesion in the left main with involvement of the circumflex. The thing here is the patient came in for heart failure exacerbation. We optimized the patient and subsequently got a cardiac MRI, evaluated all territories, did a right heart cath, which showed a RA of 4, RV of 36/4, PA mean of 20, a wedge pressure of 12 with a cardiac index of 2.8, and a PA SAT of 67. And this is what the distal left main looked on IVUS compared to the proximal left main. So again, based on these hemodynamics, we decided we are going to proceed with this case without any hemodynamic support. We went 6-7 French radial axis, could not deliver the IVUS, so we did a 125 burr. IVUS showed persistent calcium, therefore we did a shockwave lithotripsy. Then the distal left LAD area was treated with a 2.75 38 stent, and the left main LAD and circumflex was treated with a DK crush 4/48 and 3/28 with this angiographic results. And once again, no hemodynamic support. So then comes your 64-year-old with severe IPF. He's a pre-lung transplant evaluation, and he has a RCA CTO, single kidney. EF is 50%, but when you look at his right heart cath numbers, he has severe pulmonary hypertension. Your wedge pressure is 35, cardiac index is 1.8. And it is in this patient, a multidisciplinary approach helps. Patient was intubated because if this patient crashes, there is no way we are going to get him out with these kind of PA pressures. So we did a right heart cath after outpatient optimization, right heart cath during the procedure, impeller, and then a roto assisted left main DK crush PCI. And here is the IVUS, if you can see. I'm just going to proceed it further. So as we talked about earlier, post-op care is extremely important. ICU management, weaning protocol, access closure, either pre-close, your manual closure, collaboration with vascular surgery, all that is important. Usually for these kinds of cases, I like to use the micropuncture sheet and take a picture and then upsize to a sheet. Of course, in this case, this wasn't done and we had a high stick. And of course, this is a 90-year-old female with a non-STEMI. She has a known distal left main lesion. As you can see, the calcific lesion. Was managed for almost 2 years conservatively, but of course, then she came with a non-STEMI. And we did a beautiful DK crush with CSI, no problems. And then, of course, we try to remove the impeller. The pre-close fails on us and she starts bleeding. So this 90-year-old who basically survived Adolf Hitler is now about to die in my hands because of vascular bleeding. And vascular surgery had to come and put in a covered stent for us, and that's how that went. So collaboration with everyone, and even as access is as important as the results of your PCI. And this beautiful angiographic results could have been completely a post-mortem result because of this vascular complication. So weaning protocol, again, using the right heart cath to help with the timing, and impeller closure, either pre-close or dry closure in the lab versus manual closure should be considered. So to conclude, there are no right answer as to which is the right device in choosing mechanical circulatory support. It is not a crutch, but a tool to improve ischemic reserve. So whatever device can offer that is the right device for the patient. You need to balance ischemic burden of the case with patient reserve and the risk and the complications of mechanical circulatory support. Use the right heart cath before, during, and after to guide the care and tolerance of the procedure, and also to explantation. With that, I will finish and I will take any questions.
Thank you. Thanks, Raj. Great points. And I think we'll agree that the access complications can be a major issue, and that Swan Gans, the right heart cath, is tremendously important. So quick question in terms of the removal of devices. Do you have vascular surgery take them down? Do you do the closure yourself in the lab? How do you typically do it?
So we usually do it by ourselves. Like we actually do the 2 pre-closes, and when the device has to come, we bring the patient back to the lab. And sometimes in a very sick patient, we'll do it in the ICU too. But it is us who does it. But when we have complications, invariably we end up with getting contralateral access, going up and over a balloon, and then getting vascular surgery to help us with the covered stent and things like that.
Carl, how about you? And how does it work for you? Do you take care of the access, or you have the vascular team take care of it, or?
No, we always take care of our access. So we've been using Manta routinely in all these devices, and it's been really good. And even if you place the Manta emergently, what I do, I deploy the Manta under fluoroscopy, so I actually don't have to have the pre-measurement. And if that fails, we get access either from the radial axis, the left radial particularly, or from contralateral, and we go up and about, up and around, and we tamponade. The most important thing when you tamponade these lesions, remember, you can't put 6 mm balloon to tamponade the common femoral artery. It doesn't work. So you have to use like 9 mm or 10 mm balloon, and you don't inflate it. You just inflate it until like actually fills the artery, and then you just go take your gloves and go have a cup of coffee, 20 minutes and or 30 minutes or 40 minutes, and you come back and it will be good. And if that fails, there is a Viabond, really very good stent, and you have to have a big enough sheath to deploy them. And now the 018 Viabond, you can deploy it with 7 French sheaths. And if you cannot go around, you actually go ipsilateral from distal a little bit. You can just go distal and you stick. And most of the time when you have a high stick, you actually have enough room to put something. So we do all these closure devices, and even ad hoc perclose, it works. If you have a tamponade, if you put a balloon in a common iliac artery and you close the blood flow, that we call dry closure. So what happened, the arteriotomy, just leave it there for about 5 minutes, the arteriotomy actually shrinks and you'll be able to get the 14 French with a perclose.
Yeah, we do Impella ourselves, but other stuff like ECMO, usually vascular surgery, helps us with that. I like the presentation that addresses both that, how hemodynamics, LB function, right heart cath can really inform the use of devices, because I will say that there, with the use of lithotripsy shockwave, there's been like, some horrible, left main bifurcation cases that are, very prohibitive, that, really we can keep wire position and sometimes avoid mechanical circulatory support and get away. So it's been some degree transformative, but those great cases.
Yeah, so the ECMO, when you use ECMO or large bore, the tandem, the big one, we close up to 24 French with it. So it still work. And the pre-close is actually works even with the 18 and 21 French. So you have to do it at the beginning. If you do it at the beginning, but in those, I always put up kind of crossover balloon to make sure that tamponade it. So really, I can't remember the last time we called the vascular surgeons for these things. It's really, and we do about 200 of them a year. So it's like, it's really very rare. We like, if you use it, it would work.
Yeah, I completely agree. I think, for your case, because you have such a high volume, everything becomes easy. But, for the audience, people who don't do this every day, who do only a handful of those in a year, I would say don't be afraid to call your vascular team. They deal with this every day and they can bail you out, so you don't have to worry about it. So always, think about what's best for the patient versus what's more convenient, I guess. So again, phenomenal presentation again, Arashi. Thank you so much. And then Jader, looking forward.
I think you're muted.
Can you hear me there? Give me 1 second here.
Yeah, I can hear you now.
All right, let me see if I can get the right screen, get this in presentation mode. All right, is it showing there in presentation mode? Okay.
Yeah, that's perfect.
All right, perfect. All right, so actually, I mean, it's a nice, setting up the stage, because I mean, this is going to be largely vascular issues, and I think it's nice that we've talked a little bit about all devices, from Impella, from those great cases that Cal showed with Hamden Heart, and I think it's pretty, intuitive that the larger bore devices, the higher the risk for bleeding and vascular complications when you think from things that go to 7 to 8 French to 14 with tandem 15 and 17, and similar for ECMO. And of course is that the higher the large bore devices you go, there's understandably so higher risk of lip ischemia, and the complexity for post-implantation management is just much higher. And and I'll show a little bit of data briefly here, just to try to understand about what we're talking about when we think about bleeding and vascular complication. We're thinking about the IABP Shock 2 trial for balloon pump. I just want to emphasize that it was, ischemic complications requiring intervention peripheral were around 4%, and bleeding complications that were severe with 3% and moderate 17%. I think it's of interest when you look back at the SHOCK 2 trial that was not different to the control trial, likely probably some crossover, but again, 4% for balloon pump if you think about the SHOCK 2 trial. How about Impala? This is some contemporary European data. And now, again, as I said, for balloon pump around 4%, and here they actually had some patients as a control group from the IEBP SHOCK 2 trial. But now if you think about Impala for peripheral ischemic complications requiring interventions, about 10%, as you can see here in the both sets of analysis that they did in this particular study. How about US data? US data now, if you think about bleeding, major bleeding pre or during PCI, it actually goes from a quarter to a third of cases and substantially higher compared to balloon pump. Balloon pump, it's around 15%, for Impala, 28 to 32%. But again, just to illustrate that when we're using these large bore devices, we want to use the best techniques we can to prevent these complications. But it's important to emphasize that they're frequent. Again, a third of patients with Impala would have major bleeding according to this data that was published in JAMA just a couple of years ago. And of course, the larger you go, the higher your chances of complications. This is now for ECMO. This is a systematic review and meta-analysis looking at the data on VA ECMO. And as you can see here, the pooled incidence for VA ECMO was of 38%. And when you look at the distribution of events for ECMO, the most common things are limb ischemia, bleeding at the cannulation site, and significant bleeding. When we actually looked at the experience in Minneapolis back in 2012-13, this was at the time 37 patients that we did percutaneous VA ECMO. Our incidence was around 14% of patients that had major vascular complications and hemoglobin drops over 3 grams and transfusions were very frequent. So I think it's important to recognize that we want to use these devices, of course, in the right setting. We want to help our patients. There's clearly, very high risk, chip cases that we want to use this for, but really recognize that the published literature, even in contemporary practices for all these devices, have pretty high rates of both bleeding and vascular complications. Something that that I would be actually very interested in what the other speakers' practices is the issue, as I showed before, is that one of the highest risks for complications with some of these large bore devices is the issue of limb ischemia. And actually, in the same meta-analysis that I showed before, there's no robust randomized data that I'm aware of, but there's this data suggesting that if you use distal perfusion cannula, the odds of developing limb ischemia was actually lower. And of course, brings the point as to whether there's a value for doing this routine versus selective and how to make those decisions. But I'll be very interested in what people are doing when they're leaving the devices. And I can tell you that we don't do this on a routine basis for devices like Impala, but for ECMO it's a little bit different. And there's a lot of ways you can do this. There's a very nice review by Amir Kaki, and there's this other paper by Lika that I show. And I mean, there's multiple ways that you can do external bypass to reduce your chances for limb ischemia. And again, unaware of any robust data on whether the routine value of this reduces limb ischemia, but as I showed before, there are meta-analysis showing that it will reduce the odds of developing limb ischemia. And there's multiple approaches, so from more practical, like just radial, to your SFA, from multiple other approaches just shown here. With the Impella sheath, now through the side port, of course, you can do, you do femoral angiogram, and of course, there's some degree of subjective interpretation, as you can see here. Is this distal flow satisfactory or not? Particularly if you're sending the patient to the ICU, and how do you make the decision about whether you want to use distal perfusion or not? Most of the Impellas that I use are for intra-procedural rather than patients going to the ICU. But if you're going to leave it in, how do you make those decisions? As Cal alluded, as well as Arasi, I think it's critical to underscore that if we're for these devices, whether again structural practices, large bore, we want to use the best techniques possible. And this is to be honest, to me, it's irrespective of whether you're doing large bore or not. This applies for whether you're putting a 5 or 6 French for a routine diagnostic angiogram. You want to use contemporary state-of-the-art femoral access and use all the complementary techniques that are available. We wrote this a few years ago with Manos and others, and essentially you want to use all the time. There's no reason not to. You want to use all these techniques: fluoroscopy, ultrasound. There's less data for micropuncture, but we do use micropuncture quite a bit, and for routine femoral angiography, and really use all of this together to maximize your chances for safe access. And the other thing in regards to safe access, again, whether it's large bore or not, is setting up for success. Rather than asking, where is the ultrasound, where is the micropuncture, walk into the room, and this is one setup for how I like it. You walk right away into the room, ultrasound set up, you have the micropuncture, your stiff sheath, you have a sterile marker, you have really all the tools available at bedside, irrespective of whether this is an acute or an elective cases, and you're really set up to go. How to do contemporary state-of-the-art access, again, irrespective of what bore you're using, you identify the lower edge of the femoral head. I like to use a sterile marker to make it that really keeps me honest when I'm scanning with ultrasound about where that lower edge of the femoral head is. And then, then we always routine ultrasound for any axis. You look at the bifurcation, you find a good location, try to avoid calcium, and again, this is one example with micropuncture, and a critical point, I think, to micropuncture is that the wire, again, this wire can go into branches, can go into the circumflex branch or so on, so it should always be followed under fluoroscopy, make sure that it's heading in the right direction, and you always want to assess the needle entry point and do femoral angiography. So again, this is for any axis that you're performing. Something that I think has, really been has changed my practice is that, I would say most of the cases that I do lately are, pretty much single axis impala, and it's been pretty transformative. As many as is, with through the impala sheath, either at 10 or at 2 p.m. As shown here in the video, you can essentially puncture the sheath and bring in a 6-7 destination sheath and do essentially, or even a sheathless guide, and do your intervention through the impala, and inevitably, fewer accesses as compared to a single axis will always be better. And they're actually one of the initial experiences of this was just published in JACC Interventions actually this week. If you look at the latest issue, I believe it's from a center in New Jersey, looking at 30 cases of single axis versus 30 cases of dual axis. And as shown here, not surprisingly, when you have fewer axes, same single axis, you have much less bleeding, less hematomas, less retroperitoneal bleeding, fewer pseudoaneurysm, and it was of interest. It wasn't defined in the study how they defined like ischemia, but interesting that that was similar, 10%. But overall, bleeding complications, vascular complications were way lower using single axis. And this is something that I think it's an important tool to be aware of, technique to be aware of. Cal was talking about this. This is something that I don't do on a regular basis on my practice, but I think it's important to include here and actually to talk a little bit about it. And it's essentially the issue of dry closure. And of course, there is the dual axis dry closure and sort of like the single axis dry closure. This is a dual axis dry closure, and I'll show a video afterwards. But essentially, you do your routine femoral angiogram. You shoot the aortoiliac. You can do the runoff of the contralateral vessel. You do your routine preclosure. There are different setups for setting up. And actually will be interesting in what others do for keeping up your sutures sterile. But importantly, you bring a balloon contralateral, usually a 7x10x40 as described here. You make sure that you disappear your waveform and try not too high into your pressure to prevent vascular complications. And then you do your dry closure, and you can actually subsequently shoot that. This is actually a nice video, courtesy actually of our, let me just go back here. Of our colleague friend Alex Stradell from Innova, showing here how you usually will get femoral angiography, aortoiliac angiography. You do your routine closure, you do your whole procedure, advance impala, pull it back. And here now in the lower row, as shown here, essentially you will bring a wire across. You inflate your balloon, which again is usually 7x10x40 or so, and you perform your dry closure. And then at the end, it allows you to do femoral angiography. And if there are complications, you can deal with them if you encountered them. And this is nicely described in this state-of-the-art paper, a nice review by Kusum Lada and Amir Kaki and others. This is the dry closure I haven't seen this myself. It will be interesting in whether others have done this, but it's described in the literature, and some people advocate for it, given the fact that, again, you have fewer accesses, and this is actually one video summarizing this approach. And essentially, is rather than getting through a dual axis, you have a peripheral balloon through the impella sheath. This peripheral balloon is performing, of course, some balloon hemostasis as you pull out the sheath, and then you bring down the peripheral sutures, and I'll actually here in a few seconds, it will show the fluoroscopy of how you do that. Is you want to use a similar balloon length and size, and pull your sheath carefully. And here's, you're gonna see it in the next step in a second. Right over there, you have your balloon, and you're going to see below, essentially pull your sheath. And as you do that, then you're bringing your sutures down. And of course, with this, or the concern that I have is, as you pull the balloon, whether there are issues of entrapment or potential vessel injury. But it's another technique that's available that can be performed. And as you can see here at the end, after bringing the sutures, you will pull out your balloon. This is a single axis approach. Few cases here. We didn't talk about much of this before, but I will be very interested in the particularly actually for the for larger bore devices. But I'm a big fan for elective cases of non-invasive imaging for planning. So this is, again, just to emphasize, I think it's very valuable to use CT. You understand your anatomy, whether there's prohibitive tortuosity, calcification, vessel size. And this is actually pretty informative for your device selection, feasibility, and also site. And this is just one example in which CT guided us to go through the left side to perform PCI of anacalcific proximal AD, impella guided. Another quick case here, case that actually demonstrated actually peripheral artery disease shown here. And what do you do in this case? Is a patient that had a severe PAD with bypass on the right side, so really prohibitive. So in this case, essentially, having some handy peripheral, the skills to just essentially balloon this and bring your impella through. So again, things that you can encounter, and you want to make sure that you're able to deal with, including whether, of course, there are complications. Another case, this is and again, we intervene and did the proximally the PCI. CTO was left alone. And this case actually was pretty interesting, this third one. This is a case of a patient that had the postoperative anterior SC elevation myocardial infarction. And as you can see here, we successfully revascularized that LAD. But interestingly enough, the after successful revascularization, the patient actually persisted in pretty bad shock, and we couldn't realize what was happening. As I said, this was a postoperative STEMI, and there had been cardiac arrest following the operation and resuscitation efforts. And in the midst of now the persistent shock, we're thinking, well, let's maybe place a balloon pump and consider some support. We'll learn our nurse tells us, hey, this patient has actually pretty sizable hematoma, where the resuscitation efforts had been performed. And as you can see here, actually in access that had been attempted during the resuscitation, not in the cath lab, there had actually been this femoral perforation provoked during the resuscitation efforts. And that was the reason the patient persisted actually in persistent shock. So, required us to go ahead and perform some balloon hemostasis, and afterwards, come contralateral and place a covered stent. So just an interesting case that, afterwards we place a balloon pump, but actually some, how complications can arise even from things that happen before the patients even come to the cath lab. And I think with that, I will actually wrap up.
Awesome. Thanks, Adrian. Again, I think awesome comments about technique. There is no question that taking the extra time to get good access, get your pre-close, or get the good access with ultrasound and micropuncture can go a long way to minimize the risk of complications. I know we're getting actually almost to the end of our time, so maybe we start with Carl and then Aras and then Jadre for a final comment before we say goodnight. Carl, you're muted still.
Sorry about that. So absolutely, mechanical circuitry support is here to stay. And as we move through PCI, as PCI gets more complex, we have more complex patients and more surgical turndown. We found out that there are a lot of things cannot be performed without mechanical circulatory support devices. That not to say that everybody has to have everything. You can have balloon pump or Impella, but at that stage, when you face cases where you cannot outstrip your local resources, we have to act as a network. We have to kind of act as a team in the city or a county where people can, okay, I have an Impella, but I don't have lava or transcaval access, and I know Manos has it in his hospital, so we'll have more collaboration and access. And just one last word about the perfusion sheath. Nothing works, especially if you take it from the radial artery or you take it from the Impella sheath. They all clot. You can do them if you want 2 hours, but you send them to the ICU, they're gonna clot. The only thing, if you are a tandem or ECMO, those have a high pressure and you can put the sheath, but do not try the radial artery access to SFA or Impella sheath to SFA. It doesn't work. They all clot. And you better be careful. If you have to do it, you have to flush it every hour, and you flush it copiously. Sorry.
Thank you, Arashi.
Yeah, I completely agree with all the points Cal made. I think mechanical circulatory support is here to stay. And I think the most important thing is every time you see a 3-vessel focal lesion, that does not mean immediately the patient requires mechanical circulatory support. So you have to make sure you're doing it for the right reason, not because you want to get experience putting an Impella or a tandem or any of the support. So using the right heart cath, getting hemodynamic measurements, gathering your evidence, gathering your team, and the team starts within your own hospital before you even go to the county and the other section. So communicating with your CT surgeons, your ICU doctors, everybody, it's critical. And it's actually I would say it's a great networking opportunity to meet all the people in different areas to form a team which can help you serve your patient better.
Thank you very much, Arashi. And Jada, you have the final word.
I would just end with saying that I think, planning, methodical planning and multidisciplinary collaboration are key. These are cases that, of course, if there's an emergency in the middle of the night, you have to deal with what you have to deal. But if it's elective, you want to get that surgical turndown, you want to get multiple opinions, you want to get a CT if possible to plan or ultrasound to plan for your access. You want to have careful consent. You want to, you want to inform everybody, anesthesia, your colleagues. Planning needs to be a critical part for success, and realize that while we can do many of these things in the cath lab, reaching out to colleagues from whether that's IR, vascular surgery, CCU, anybody, can really set up for the best patient and procedural result.
Wonderful. Thank you again. Thank you, everyone. We're a few minutes past 9 o'clock, but 10 o'clock Eastern time. But again, thank you so much for all the excellent presentations. Thank everyone who participated in the webinar. Also, thank our supporters, Abbott, Boston Scientific, and Medtronic. And again, look forward to seeing you next week in the CTO Summit in New York. It looks like the meetings are back up. So again, thanks everyone, and have a wonderful night.